So I'm going to kind of cover everything that you will need to know as far as how to use the device, how to maintain it, how to implement it, and then the biggest question that the clinical staff has is what are we looking for? And so we'll go through several case studies. My name's Darlene. I'm also a hygienist, so I use this on patients in actuality, so that kind of helps me to better educate you on what you're looking for and where there's different scenarios. I've been with Oral AD since February. I really enjoy the motivation that they have because it really is all about making differences, screening as many patients as you are in contact with so that we can potentially find something. If we're going to find something, we want to catch it early so that we can potentially save lives. So that really is our goal. So for those offices that haven't used a previous technology, I started off with if you change the way you look at things, the things you look at change. When we went to school and we learned how to look for oral cancer, we were trained to look for the obvious stuff, the red and white lesions, the lumps and bumps. You know, there's certain classic things that we see that tips us off that there's something of concern that we want to refer out for a biopsy to get diagnostic results. So we're trying to change that thinking process because 63% of oral cancers that are found in dental practices are already in late stages. And so the 5-year survival rate has not changed in 3 decades because of this. So the more offices that we have that are using these additional technologies, the better chances we can start to change the trends by catching things earlier. That's why mammograms and pap smears and prostate tests have all been successful with increasing the survival rate for patients is because they're not having symptoms yet. They're catching it early enough that their treatment outcomes are much more successful. And so that's kind of the same thought process as we present this to our patients. We just let them know we're doing an oral cancer screening. We have a technology that allows us to do a better job at that screening, or we've recently invested in a new technology to allow us to see things that we can't see in a regular exam. And so we just can better stay on top of things. So what came with your device? I know that one of the offices hasn't received theirs. Dr. Paolo's office, I didn't ask you guys, have you received your Oral AD kit yet? Are you guys on mute?
Were you talking to me, Dr. Paolo?
Dr. Paolo's office?
Yes.
Have you guys received your Oral AD device yet?
Yes, ma'am.
Okay, perfect. Do you have it there in front of you?
No, but we can go get it.
Well, no, it's okay. Your device hasn't been registered yet, I don't believe, because I don't have the tracking, like I don't have the ID number. And same thing for the other office. Once you get the device, go and register so that activates your 2-year warranty, but it lets us know exactly what device number you have. And it's inscribed pretty large on the side of the device. You can't miss it.
Okay,
so your Oral AD will actually be in an Oral AD box along with some glasses for it to filter certain wavelengths. You've got brochures, cytology kits, and then your smart filter. And this allows you to take pictures of the things that you find. The glasses are a filtration system, so it's not protection. It's not like your UV or your curing light. Your patients do not have to wear these glasses. The reason there's 2 pairs is if 2 clinicians want to look at the same time. So maybe the hygienist sees something suspicious. She wants the doctor to come and reevaluate what he or she found. And so you guys can both look at the same time. That's the benefit of having 2 pairs of glasses. It's not necessary for the patient to wear them. When you put the batteries in, the positive goes down with 2 of the batteries. So you just unscrew this end piece. It's called the tail cap. The button is also at this end, and then you just drop the batteries in. When you turn the device on, it should be a constant, steady, bright stream of light. If you don't feel like any of those things, it's flickering or it's not really, really bright when you initially set it up, then go ahead and unscrew the tail cap, take the batteries out, put them back in, make sure that both positives are facing down, and then try it. Because sometimes that tail cap just isn't screwed on very flush. If it's after doing that troubleshooting, it doesn't correct the issue, then give us a call and we'll see if we can help correct the issue. To disinfect your unit, you just spray and wipe the entire thing. Any hospital-grade surface disinfectant is suggested or recommended. But when you're cleaning the glasses and the smart filter, if you use those chemicals over an extended period of time because of the high alcohol content, it will cause them to deteriorate and they'll kind of start to fall apart after about a year of use. So we do recommend warm soapy water is really ideal, or if you have some cleaning agents that are the lower alcohol. So you may want to get additional brands of wipes for that. We're actually testing a couple right now to see if that would be a good recommendation. But bottom line, I would say if you do have to spray and wipe them, just at the end of the day, use warm soapy water to rinse them and clean them so that those chemicals don't just continue to seep in on there. The other set of glasses is designed a little bit larger, so if anybody in the office has existing eyewear, these are going to be the ones you tend to grab because they're going to actually fit over your glasses more comfortably. So that's why there's two different fits. The battery life lasts about 100 to 110 minutes. There's no way for you to keep track of when you hit that threshold. So the general rule of thumb is check the gums periodically. If you're shining the light, the marginal gum line is always a little bit darker. It's kind of more of a maroon color because of the increased vascularity. Whereas the attached gingiva, the vascularity is kind of more dispersed out, and so you get more of that green reflectance. And so when those two lines kind of blend and you can't really distinguish where marginal tissue ends and where attached gingiva begins, then you know you've lost too much power in the batteries, and then you just throw them out and start with a new pair. Actually, yesterday I temped in an office. I was using the device, and I felt like it was pretty bright. I mean, I haven't checked the gums really because I just, have a pretty good gauge of what it's supposed to look like. And in the middle of use with this patient, I mean, it literally just drained out to nothing. I mean, and so I didn't necessarily have to get at that point where I was checking the gums. It was like, okay, it's time to replace the battery because it died on me.
What size battery does it take? D?
What was this question?
What size battery?
It's CR123A lithium.
So it's a special battery.
It's a lithium battery, yeah. I wouldn't say special. I mean, it's a common lithium battery. You can get them at Walgreens or CVS or Radio Shack. I will say that because we buy so many at one time, you can get them for about 50% off of what you would pay retail through us. We sell 18 packs for $65. We also have a referral program. So if you guys are part of a study club or have dental colleagues that are interested and they end up purchasing our device, then we give your office a year's worth of batteries as a thank you for that recommendation. So those are the two ways to get more batteries. You do need to use a U.S. manufactured brand, which is either Energizer or Duracell. If you use a non-U.S. manufactured brand, we can't promise something wouldn't happen to the device and that it wouldn't affect the warranty. These are the two that have been tested and FDA approved for use.
Okay.
So when you go to do your oral ID exam, you want to turn your overhead dental light off at minimum. There's some operatories that have windows and are a little bit brighter than others, and so if you want to dim extra lights down, turn extra overhead, like ceiling lights off or close the blinds, you definitely can, but overhead dental light at minimum. There's no set distance required with where you hold it. Just know that if you're holding it closer to the mouth, you're going to have a smaller focal point but a more intense light. If you hold it a little bit further back, then that focal point expands a wider area so you can see more surface area at one time, which is good because you definitely want to compare surrounding tissues when you're helping to find abnormalities. There's a couple of videos online you guys can watch if you go to oralid.com, click on training and then sample example, and it kind of demonstrates what it looks like to retract with one finger, follow along with your oral ID device as you're doing the intraoral exam. And then the other video we have is patient education and kind of how you would present it. And it's doing the white light exam and the oral ID exam. So that one's a few more minutes. But I can't link the audio up for you guys to hear it. So just if you have not had experience with doing a screening with an adjunct technology, then it would be beneficial for you guys to watch that at your convenience. So what are you looking for? This is always the biggest question. First, I start off with look for the obvious. As I said earlier, 63% of what we find is already in late stages, so we want to still find those things and refer them out to the specialist as soon as possible because there's a good chance if it is cancer, it's already advanced. But also, when you're doing your white light exam, you will see where there's pigmentation or where there's a cheek bite or where there's geographic tongue or tori, kind of those normal variations that we see on a regular basis, because some of those things could look dark under your light, but it's not something that we have to be concerned with. Our device is a detection tool. It helps to show you the things that you can't see in a white light exam. So if you can already see it in a white light exam, chances are that it's not something you need to be worried about when you go and repeat the oral ID exam. And I'll help you through that process of elimination. So when you see something healthy, it emits bright white or green light. It reflects that light. So there's kind of that green glow, and that's just due to optical biomarkers that naturally will fluoresce in healthy tissues. Abnormal tissue will have what we call a lack of fluorescence. It appears dark. Dark doesn't always mean black. It could just be darker compared to everything else around it. And I do have examples of that, so you'll see what I'm talking about. But what causes a true lack of fluorescence is an alteration in the collagen cross-links. This could be from thermal damage, so burns, pizza burns, soup burns, mechanical damage, and so that could be cheek biting or toothbrush abrasion, or chemical changes. Chemical changes could be acid erosion. It could be use of drugs or chemicals, the irritations that could cause. We also have a patient that had acid erosion from acid reflux. And so there's a lot of stuff that will look dark under your light. Again, doesn't necessarily mean it's cancer, but it's just tipping us off to something's there. And then we kind of have to use our clinical judgment and our experience to determine what the next step or follow-up process should be. All those things that I just described have an increased metabolic activity. Basically, it's inflammation. Anything that the tissue is trying to recover, heal itself from a trauma, that's going to look dark under your light. So what I call dark normalities. Marginal tissue, as I showed you earlier, is more of a maroon color because there's increased vascularity. So anytime you're looking at vascularity, that could be dark. If there's pigmentation, geographic tongue looks dark. All those irritations I just talked about. Sometimes it's just anatomical features. So you look at the papilla on the tongue. There's these tiny little polka dots. They're not super dark, but it makes sense. We know that the papilla is, that there's going to be those variations. It's not as noticeable in the white light exam, but it makes sense. And so we're not too worried about the things that kind of fit in, or especially something that covers a generalized area. Cancer isn't going to occur in any sort of symmetry. There's not going to be any rhyme or reason. So for that reason, also, if you see it bilaterally, typically we don't pay too much more attention to something that you see on both sides. So if you see something suspicious on one side, first thing I would do is look at the opposing side and see if it matches. If it does, then move on. In the tonsil pillar, oftentimes that's a common occurrence. You may even see pink and orange colors under your device. That's telling you that there's a bacterial or fungal accumulation. If you have a patient with poor plaque control, you can almost use it like you would disclosing solution as far as the educational aspect. Give your patient a mouth mirror, put the glasses on them, shine that light, and they will see all that pink bacterial growth on their teeth. And then once you've cleaned them, you can show them again the difference. And so like I said, it's like using disclosing solution but without having to deal with the mess. Or if you see adolescents, it could be an extra kind of step that you do that they think is kind of cool. So here's the attached and unattached gingiva, a little bit bigger, blown up. You see the marginal is consistent, wraps around every single tooth, that it's a little darker. You can see all the little striations in the attached gingiva that is vascularity. So we're not worried about that. It's a pattern that's consistent. Another thing you can do to double check yourself is when you see something of increased vascularity, if you press on it, it's going to leave a white spot briefly, or it's going to go light and then dark again because you disrupted that blood flow. And so if it blanches, that's telling you it's vascularity. If it doesn't change color when you press on it, then that may be what we consider a true lack of fluorescence, and you might want to bring that patient back for a follow-up in a couple of weeks to see if maybe it was just trauma that has cleared up and gone away. Here's a little cheek bite, and when I say little, I mean it's not anything anybody would have red flags about. There's a little tiny hematoma where they bit themselves. It looks a little bit larger under the light, probably because there's some inflammation that kind of expands past that hematoma. If you ask the patient if they remember biting themselves, they may or may not remember, but the bottom line is no matter what you find, you need to tell the patient that you're doing an oral cancer screening, and you need to document what you found, so that 6 months from now you can reassess and make sure that whatever that little thing was is not there anymore, but also tell the patient that they need to help you to monitor these things from home. No matter how small something may seem, they need to keep a watch on it and let you know if there's changes or not improvements. Here's geographic tongue, and geographic tongue looks dark under the light. I had 2 patients yesterday when I temped an office that had geographic tongue, and it's hard to describe to them. If no one's ever told them what it is, it's kind of hard to explain it. The way I describe it is it's like carpet. If you pull carpet in one direction, it looks light. When you pull it in another direction, it looks dark. That's kind of what the papilla do on our tongue, and it makes these patterns. So it's not anything of concern, but it does look darker under our light. In this case, there's actually kind of a white rim to the border of this area. And we've learned that erythroplakias have a 30% chance of turning into a malignancy. And so where you're 90–95% sure this is just geographic tongue, because of one simple characteristic difference, you might start to question, but what if it's not just geographic tongue? What if it is something worse? And so there's a few options you have. You can have the patient come back 2 weeks later to see if it's relocated or changed. You can document it in the chart and just reevaluate at their 6 months or their next scheduled cleaning and make sure that things have kind of moved on and that it's not, it doesn't look exactly the same or gotten worse. Or we have our cytology test now available to us, which is great. It's a very simple, non-invasive way to collect some information and get a diagnostic report. So again, oral ID, this helps us detect things sometimes that we can't see in a white light exam, but Site ID is going to give you the diagnostic answers you're looking for to determine, is this something that we need to have removed or be biopsied, or is it something that we can just keep a closer watch on? If you see white in both exams, we're not worried about that. This is hyperkeratosis, and that's okay. And so let's start to look at the abnormalities. This is an illustration of the progression of cancer, starting with normal tissue, progressing from mild to severe dysplasia. On average, 5 to 7 patients a year are found with dysplasia, and there is a 5 to a 20% chance that dysplasia can turn into cancer. So it doesn't always turn into cancer. It's actually kind of lower on the percentile. But the point is we have a lot of patients being diagnosed with cancer annually. It's about 43,000 people are getting diagnosed with oral cancer. And so if we can catch it in these early stages, this is where we start to change the trends in the survival rate. And so this is the kind of stuff that if we're going to find, we want to find it at this stage. Carcinoma in site 2 is the initial point that the cancer has kind of taken over the entire epithelial structure, but it still typically has good response to treatment at this point. It's whenever the cancer breaks through the basement membrane, starts to metastasize, starts to spread through the lymph system, that things start to get more complicated. And 63% of oral cancers that are found without the use of these adjunct technologies are already in these late stages. So as we look at the progression, kind of going with dysplasia, the doctor had seen this red area in the back of the throat, followed the white light exam with an oral ID exam, and it just confirmed that the red area he was seeing also had a lack of fluorescence. But he wasn't expecting to see this other dark area to the side. So this is the back of the throat where it kind of curves down to the uvula. So you come over and you look at this curve on the white light image, and you can start to see a little bit of a white and red lesion there. It's not as obvious as this big red spot, but having this device, it kind of reiterated the focus and said, okay, it's not just this big obvious, but there's also something else. So the fact that there was 2 lesions side by side, that they looked different, the location of where this was, the doctor referred this patient out that day. Like, I want you to go to the specialist. We need to get a biopsy. It came back as dysplasia. So fortunately, it was caught very early. And I'm not sure if they ended up removing the dysplasia from this patient. I did have a gentleman that had dysplasia due to dipping. He stopped dipping. When they retested him, the dysplasia had gone away. So sometimes the irritation, you remove the source of irritation, the dysplasia can take care of itself. This area is not a common area, for abnormalities or for traumas to occur. And so I think that probably the doctor felt like, having this removed would be the better route. Here's another case. The patient said they had a tingling sensation in the palate. There's kind of a generalized redness there. And so maybe without the use of fluorescence, you go through a series of questions like, are you a smoker? Have you had a cough? Have you burnt your palate? I mean, like what kind of things could cause this generalized redness? But by doing the oral ID exam, it really changed the focus to one central area. So where it was kind of red all over, there was one spot of of significant concern. So the doctor decided to wait 2 weeks and reevaluate because the palate is a common area of trauma. This is a common spot where people poke themselves with chips or burn themselves. And so he said, let's wait 2 weeks, see if it goes away, if it heals. And at the 2-week mark, it had not changed. And so he did end up doing a biopsy, and this was moderate dysplasia. So this is a little bit more progressed, a little bit higher up on the risk category. If you did a cytology test in this area, it would tell you if dysplasia was present, but it could not tell you if it was mild, moderate, or severe. It couldn't tell you what level of dysplasia. And so that is something that you would still need to do a biopsy to find that out. And so we're not saying cytology is intended to replace the need for biopsies, but sometimes it gives you that extra information to help you determine if a biopsy would be beneficial. This area looks pretty suspicious. There's an ulceration. There's a redness around the border. You don't need oral ID to tell you that this doesn't look healthy. But the doctor did take pictures with both exams. He referred this patient out, and some specialists may use this light to help guide them as far as where they want to do the biopsy or not. This was carcinoma in situ. So this was initial stage cancer. Typically, patients' treatments are very successful. This patient, however, had COPD and a lot of other risk concerns. So when he went under anesthesia to have this area removed, he actually did not make it out of the surgery. And so there are sometimes complications that can occur, in addition to the oral cancer. So, not every story ends up being a happy story, but we just kind of wanted to share these images that we have so that you can kind of see examples. This is another one of those cases that didn't end up so fortunate. This gentleman went to the doctor every 6 months for cleanings. The dentist had seen something on the tongue, but it was something really small, and he just didn't feel like a biopsy was necessary. But he told the patient, let's keep a watch on it and see if things change. If they do, then I might refer you out. So kind of think about that little cheek bite, that little tiny cheek bite picture that I showed you earlier. I mean, you can imagine that happens all the time. We see something, but it's not too bad looking. It's just, maybe it's nothing, so we just kind of tell the patient we'll keep an eye on it. Well, the patient continues to come in every 6 months, and there's no change, and there's no change. And then after 3 years of that routine, patient comes in, and it looks like this. So it almost looks like it just blew up overnight or within a short 6-month period of time. But in reality, this is something that's been developing from day one, from the very point in time that the doctor had seen something. And so had he had fluorescence, maybe he would have seen something larger under the surface that he wasn't really in tune to with the white light exam. Also, had he had a cytology test, he could have at least in a non-invasive manner, just to be safe, make sure that that little bitty thing that he had seen was nothing. The other thing the doctor could have done that really would have made a difference is just a simple health questionnaire and patient interview. That is what ADA says is part of your oral cancer screening, is doing that health questionnaire, because it tips you off to a lot of beneficial information. Had the doctor taken the time to ask pertinent questions of this patient, he would have known that this patient had lost both of his parents to oral cancer as well. So just think about that for a second. You have a patient, you know he's lost 2 parents to oral cancer. You see something on the tongue, no matter how small it is, you kind of are on high alert for that patient. And so again, maybe he would have referred him out for a biopsy or at least done a cytology. So this is how you're going to use these tools to your benefit. This was an invasive squamous cell carcinoma at the point in time they referred the patient out, and he passed away 6 weeks later, 6 weeks after that referral. This is another case of an invasive squamous cell carcinoma. This, again, is something in later stages. The patient ended up losing a pretty good section of his maxilla. But this is just some images of what you may find, what things may look like with your device. This is a little HPV lesion. So you can see this little white kind of hyperplasia on the lip. So remember I said earlier, if it looks white in the white light exam and white in the oral ID exam, we're not worried about that. So it looks kind of white in the white light exam, but it definitely looks dark under the oral ID. Now, I wouldn't say this is black by any means, but you compare all the fluoresced tissue to where it's not fluoresced, and it sticks out. So again, this was an HPV lesion. If you were to do a cytology test in this area, it would tell you that HPV was indicated, but we would have to go back and do a secondary test that was specific for HPV. to let you know what strain of the virus this patient has. The benefit of knowing that is that there's a couple of strains that are linked to cancer. In fact, it's one of the leading causes of cancer right now, and so it is helpful for the patient to be aware that they may have that higher risk. At the margin of the crown here, also you can see that there's a little pink area. I don't know if that's just plaque or it could be recurrent decay. But when you're doing your soft tissue exam, look at the hard tissue, shine the margin of the crown. You never know what else of interest might kind of jump out at you. This doctor had newly gotten our device, and she was doing a visual and palpation exam. And some people might kind of think this looks like tori, and there is some tori part of this lesion, but the center area was kind of soft upon palpation. When she did the oral ID exam, it showed this lack of fluorescence, this darkness. Granted, the tissue color change doesn't look different at all from the white light exam. So obviously she was concerned, sent this out for a biopsy. This came back as an aggressive ameloblastoma. So good news, it wasn't life-threatening cancer. But it was, however, an aggressive growing tumor. The patient did lose a pretty good section of her lower anterior jaw. She lost 9 teeth as well, getting that tumor removed. But when you Google aggressive ameloblastoma and you see how progressed these tumors can get, we were glad that things were caught at the point in time that they were, that it didn't have a chance to get worse. So it's not just about finding cancer. Here's another scenario. This was a hygienist that they had newly bought our device, and so they were kind of playing around screening each other, which is something we recommend for you guys to do. When you get your device, screen each other, make sure everybody's nice and healthy. Also practice taking pictures at that time, so you kind of work through the troubleshooting, and when you go and you take images with your on your patients, you've already kind of worked out the kinks. But so this is a hygienist, wasn't expecting to find anything. There's this red area that she was not aware of prior to this point in time. So they did take a picture with the device, and they ended up doing a little cytology test. So a non-invasive way to determine what's going on. So the cytology came back negative for malignancy. So most people would have been happy with that, and never really looked back. But she's a hygienist, and so she said, I didn't know about this before. It's great, it's not cancer, but I don't feel like it's normal. And so she actually went and followed up with an ENT. And the ENT was able to give her the answer she was looking for. It was simple. She had GERD. This is a result of acid reflux. She slept on the same side of her body every night, and so the acid's just kind of sitting back there. The ENT told her, had this not been discovered at this point in time, he was pretty sure that in about 3 years that this would have turned into dysplasia. So it's all about finding those red flags. It's not just about the obvious cancerous lesions. It's the things that we can maybe change the path so that it never gets to that point in time. That's how we're trying to change how things have been done. In order to do that, we recommend implementing the FACT oral health protocol. And so that's kind of what I've been talking about. Bring the patient back for a 2-week follow-up. If it's still there, maybe do a cytology test. So you're using the fluorescence on every single patient, and then when you find something suspicious, if you want to do a cytology test, that's the route, or that's the avenue for diagnostics, the diagnostic step. So always update health history and ask pertinent questions. Perform that visual and palpation exam. Palpation is very important because a lot of cancers are in the base of the tongue and the back of the throat where you can't see them no matter what technology you're using. So palpation is going to help you to determine maybe there's something going on that you can't see. If you see something or feel something suspicious, document your findings. If you don't feel like it's super urgent or you don't have a lot of red flags, then say, you know what, I'm pretty sure it's nothing, but I'd like for you to come back in 2 weeks. Let's just reevaluate things. If at the 2-week mark things have gotten worse, send them to the specialist. At the 2-week mark it hasn't changed, it still looks dark, maybe do a cytology first to see what that tells you to determine if the biopsy would be beneficial. We have a mouse map available on our website. If you go to the download tab, you can print off as many of these as you need to. If your office is paperless or you don't want to go that route, you have your smart filter for photo documentation. You need to always turn the flash off of the device that you're using. You need to grab somebody to help you take a picture because you're likely holding the device with one hand and retracting with the other, so you don't have a means to pick up a phone and take a picture. So grab somebody to help you take the picture. You want to dim the additional lighting in the room. So you already have your overhead light off when you do your oral ID exam, but when you take pictures, turn extra lights down, your pictures will come out much better. And also, if you kind of point the lens in the same direction as where you're shining the light. That's going to help prevent from shadows and inconsistencies when you take the picture. So this office was gracious enough to send us an example of a white light exam and an oral ID exam. However, the oral ID exam didn't quite turn out as they had expected, and so it ended up them calling us and saying, what did we do wrong? So I know they turned the device on because you can see that the teeth are kind of green as it gets darker in the back of the mouth. I also know that they have the smart filter over the lens because then nothing would look green, it would look blue. I can see in the background the lighting's turned down. So what I think happened is they forgot to turn the flash off. And so that's why there's kind of that increase in that white light. So one little simple step could make all the difference. And so as you're taking pictures, just kind of go through this troubleshooting to help correct. I'm going to talk about the cytology for just a minute because this is kind of new. I don't know if you guys have ever had experience with oral CDX or brush biopsy, but people see site ID and think it's the same thing, and it's not. Site ID is a cytology. It's more like a pap smear. And so for those women who've ever had a pap smear, you know it's not painful as far as the scraping aspect because it's not scraping. We call this a cytology swab. It's a bristle brush, but you're just collecting the cells on the surface. We actually don't want any bleeding in the sample whatsoever, so it's very, very comfortable for the patient. Because it's not a biopsy, the hygienist can also perform this test. Original pap smears that came out, they were only about 50% accurate, so we've learned that once you collect the cells, instead of smearing it directly onto the slide, you put it into liquid first and then prepare the slide. It gives us a much more accurate result. And so it makes the pathologist's job a lot easier to look at these cells individually, to tell us what the nucleus looks like, to look at the characteristics. And for that reason, that's why we don't get atypical readings back. We usually get, negative or positive for malignancy, if there's indication of HPV, if it's dysplasia. And if it's none of those things, there's a lot of descriptive terms that also help guide us as far as do we want to keep an eye on this or not. Indications for use with your cytology would be to validate the need for referral or to provide your specialist with additional information. I have had stories told to me where a general practice had sent a patient to the specialist because of something they had seen with their light, something dark, but it wasn't something you could see in the white light exam. And so when it got to the specialist, they kind of said, well, I'm not real comfortable cutting on something I can't see, so we'll just keep an eye on it. But think about that for a second. If they don't have fluorescence in their practice, what are they keeping an eye on? There's nothing to keep an eye on. And so if that's kind of the thought process of the doctor that you refer your biopsies to, just accompany each referral with a cytology test or a cytology report. It's going to confirm that need, and not only does it give your surgeon or your periodontist reassurance, but it gives you and the patient reassurance that that biopsy is necessary. If it were my mouth, and somebody's seen something that they were kind of like, well, it doesn't look too bad, but, it looks dark under my light, and I'm just curious to what it is, we can go two routes. We can either take a little sample of the cells, or we can, you can go to another doctor and have a section cut out. What is your option? I mean, everybody would say, let's go the non-invasive route first, see what that says, and then we'll determine if it's beneficial to go the next step. I'm sure all you can kind of agree with that, and that's why I love cytology, because it just seems like such a quick way to answer those questions that we've kind of always been left with. Some patients may refuse a surgical biopsy, whether it's a fear or a money problem, maybe it's time constraints. If they're a medically compromised person, maybe they are wheelchair bound or they rely on somebody else for transportation. In that case, you don't necessarily have to wait 2 weeks to see if the lesion went away and then do a cytology. If it's going to be easier for them to do the cytology at that initial point in time, then go ahead and do it. They appreciate you, saving them those extra inconveniences. Same thing with patients that are about to leave to go work overseas for the next few months, or maybe they're about to go on a 3-week vacation. Who knows? They don't want to be thinking about this the whole time they're gone. So you can do a cytology right then. Also, your flight risk patients, those are the ones that call you when there's an emergency. Maybe they cracked a tooth or there's an abscess, and when they come in for this emergency, you notice something suspicious with your oral cancer screening. And so that's a patient that if you say come back in 2 weeks so I can look at this area again, you're probably not going to get that opportunity. It may be another several years before they come back in, and then whatever you found could have been something early stages that then at that point in time is late. So that's another person that you want to do a cytology on while you've got them in the chair. And
Can I ask you a question?
Yes, ma'am.
On the cytology test, can we file that with insurance?
Yes. And I have the last little section, I go through all the coding for you.
Okay,
and I'll
I'm sorry.
also email something over that walks you through it as well.
Okay, great. Thank you.
Okay. So here's another case study. This is another instance. So the doctor had been using our device for a couple of weeks, and he didn't see anything for all that time, and that's normal. So I don't want you guys to start to get paranoid that, I'm not seeing anything, so I must be missing something. That's not necessarily true. Also keep the peace of mind of knowing that just by looking at all, you're doing so much more than so many other dental offices out there for your patient. So just keep that in the back of your mind. But here the doctor had not seen anything for a long time, and then he finally finds something, and I think he was just caught off guard, and he kind of didn't know what to do with it. So he told the patient, I think I see something, but I'm not sure. I'm going to call the company. I'll give you a call tonight. So he called us and said, I think I found something. What do you think? He sent in the pictures. I said, yeah, I think you found something, but what does something mean? I mean, something's kind of used loosely, because did the patient bite themselves, or did they burn themselves, or do they just chronically chew on their tongue? I mean, there's a lot of traumas that could cause the same look. So did you ask the patient if they remembered doing any of these things? And the doctor says, no, I didn't. And I said, the other thing I would have probably done is pressed on it, given it did the little blanching test, because if it changed under compression, it could just be a little cluster of blood. Did you look bilaterally to see if it's consistent on both sides? So these are some of the extra things that I would have done to kind of help guide me to what is my next step. So with all those questions being answered, maybe you said, you know what, let's just have you come back 2 weeks later, see if it's still there, because maybe you bit yourself and you don't remember it. And so if that's the case, that trauma won't be there and it won't look dark in 2 weeks' time. But if after 2 weeks it still looks like this, maybe go ahead and do a cytology test to determine what the answers are. And he said, oh my gosh, I totally forgot that I had those cytology kits. We send them with your oral ID when you purchase them, and then they get stuck back in a cabinet or whatever, and they're just forgot about. And so he said, that's what I'm going to do. I'm going to call the patient. Well, I haven't gotten an update, and I'm dying to know, like, what came of this patient. Did it go away? Is it still there? Did you refer him out for a biopsy? I know that we haven't gotten the cytology in, so they didn't do a cytology that I'm aware of. So it's pending. I'm sure you guys are just as curious as I am what came of this. But let me show you, we have another case that came in, kind of the same area of the tongue, same side of the tongue for this patient. This is a 63-year-old male, heavy smoker, and is small, or I guess it doesn't look super dark, but you can see this differentiation compared to all the fluorescent tissue around this border, and this was a confirmed case of mild dysplasia. So this is something caught in the earliest stages, something you wouldn't have seen otherwise. This is the second time something has come up in this patient's mouth, and so from here on out, I think the surgeon's removing everything that develops, because they just feel like that he has a really high risk. So I don't know if the other guy has dysplasia. There's no way of knowing until we do the diagnostic steps. But because of this, I am really curious. There's a YouTube video on the website. If you go to site-id.com, click on videos. There's a couple of options. One shows you how to perform the cytology and how to distribute the cells into the cup. Also, one shows you a brush bending technique, so harder to get to areas, you might have to bend the brush down a little bit. There's no point in watching this now. At the point in time you need to do a cytology, which could be weeks from now, go and watch that video, and that will just walk you through how to perform it, because I would hate for us to get a sample that didn't have enough cells for us to be able to test, and then you have to call the patient and tell them, hey, we need to come back in, we got to redo it. So just watch that video, and it will really help you. Once we get the cytology results, so you guys mail it to us, and the postage is included in the cytology box. You mail it to us. 3 business days later, our pathologist has read the results for you, and so we fax the report to you at that point in time, and we call to make sure somebody received it so that it's not lost in space. So this is an example of what the cytology would look like. It has patient information, tells you if the sample is adequate. This was the site in question for this particular cytology. It said negative for malignant cells. And then the description said anucleated squamous cells, which, no, it's not cancer, but there is an abnormality. Anucleated means the nucleus is missing in those cells, which is not normal. It also said excessive bacteria and suggested of leukoplakia. So leukoplakia has a chance to progress into cancer as well. It's not as high as erythroplakias or dysplasias, but there is an increased risk. And so, talking about catching things at the earliest possible stages. Now, do we need to go and cut leukoplakia out? I can't answer that question for you. You need to talk to your specialist. You need to talk to the patient as far as what their comfort level is. Do you want us to have this removed, or do you want us to keep an eye on it? Also, look at other health concerns. Are they a heavy smoker? Do they have HPV or any other autoimmune deficiency? Have they ever had cancer before? All these kind of things help to guide you through what the next step should be. Once we receive 5 cytologies from your office, we send you a certificate that says you're a FACT certified provider. So you can hang this on your wall. You can advertise with it. We also have a press release that you can use that you can do like a print, like an article that talks about what you guys are doing to go above and beyond the standard of care in the fight against oral cancer. So why do we screen every patient? Why are we sitting here going through this training process? Why are we investing in these adjunct technologies? Well, it's because as dental professionals, the oral cavity is our responsibility. It's nobody else's responsibility but ours, and we're the ones that come in contact with these patients on a daily basis. Oral cancer kills 1 American every hour. So this hour training that we just did, somebody's died due to oral cancer. When you've worked an 8-hour workday, including your lunch, we've lost 9 people due to oral cancer, and we have the ability to start to change those trends. 1 in 92 adults will be diagnosed with oral pharyngeal cancer in their lifetime. Average dental practice sees about 2,000 patients a year, so that's a lot of opportunity. I kind of refer to it like a needle in a haystack because we look from each one of our patients, and you don't know who has an increased risk. You don't know who maybe has already been exposed, but we have to screen every patient so that we can find the ones that we can help. I was talking earlier about mammograms and pap smears and prostate tests and 5-year survival rate. The 5-year survival rate for all cancers has steadily been improving because of these precautionary tests and because of increased public awareness. But oral cancer is the only cancer, the absolute only cancer, that 5-year survival rates hasn't changed in 3 decades. You know what that tells me? That tells me that what we have been doing isn't keeping up with technology, isn't keeping up with what other advancements in oral cancer discovery has occurred. We have to incorporate, we have to use these fluorescence technology. You have to convince your patient that it is pertinent and relevant to do these exams because that's how we make a difference. Also, you will have patients that say, oh, I don't smoke, so I don't want to pay the extra copay to do this extra test. Well, that's fine. I understand you feel that way, but there's been new developments in oral cancer. 50 to 60% of oral cancers that are diagnosed do not fit in the traditional demographic. It's affecting non-smokers, and it's affecting a younger population. There's a lot more occurrences of oral cancer in younger adults now, and this is due to the increase in HPV. And then some people say, well, I've been with the same partner for a long time. HPV is just a sexually transmitted disease. That's not true either. HPV can be transmitted through saliva, so just kissing someone. Skin-to-skin contact. I mean, you can get it easily. That's why they're saying 3 out of 4 people will be infected with HPV at some point. Now, I said this earlier, only about 5 strains of HPV are linked to cancers, so the majority of the people that are infected don't have the cancer-causing kind necessarily. But when you have a patient in your chair, how do you know who is who? There's no way for you to know this. So we have to screen everybody so that we can make that difference.
Excuse me, my hygienist has a question.
I'm sorry?
The hygienist has a question.
Oh, yes.
For DDP, at what age are we doing this on children or teenagers?
I don't know what DDP's requirements are. CDC, the Center for Disease Control, suggests 17 years old and above.
Thank you.
Okay. And also, this is kind of a side note. If you have loved ones or you yourself are under 26 years old, you can be vaccinated against some of the strains of HPV. It's the ones that are highest linked to cancer and then a couple of additional like wart-type simplex strands. It's a 3-series inoculation, and this has been approved for boys and girls. So if you take your kids to the pediatrician or you've heard friends or family kind of talking about it, it's something that's definitely recommended to help prevent their potential of getting oral cancer. Because where I said there's been a 225% increase in oral cancers related to HPV, that was, I think, updated in 2007. By 2025, I think they're saying 800%. So it's a growing epidemic. They're not expecting it to get any better anytime soon. So get your loved ones vaccinated to help protect them. If we can catch a lesion in stage 1 or stage 2, our patients have an 83% chance to survive the cancer. Stage 3 lesions drop their chances to about 50-50, stage 4 down to 34%. And so this is why we need to use these screening devices to catch things earlier, the things we can't see. That's where we potentially save lives or at least help patients maintain good quality of life, because late discovery is very deforming, and the suicide rates are higher in those patients. I can't even imagine. They survived the cancer and they wish they wouldn't have, because they're eating through a feeding tube or they're just left so malformed they don't leave their house. So we catch it early enough, maybe their surgery is less evasive, and maybe they get to live a healthy, happy lifestyle. And so I know that we kind of ran late with getting started, a little late. If the clinical staff has patients there and they need to go, this last little section is to the billing department, the people who file insurance. Dental insurance code for oral ID is D0431. I don't know what DDP is recommending charging for this, but you do want to specify what device you use. So when you file D0431, explain in the description or in the narrative or somewhere, say oral ID adjunctive screening device. 15 to 35 is kind of the oral ID adjunctive screening device.
Okay.
And then we recommend the copay recommendations are around 15 to 35. I feel like DDP is 25, but don't quote me on that. The cytology code is D7287. Now this gets a little tricky, okay? Cytology is not something you guys have ever probably billed for, because it's a newer code that's being used because we didn't have site ID before February. And so maybe oral surgeons or other instances were using this, but in general practices it wasn't very common. So D7287, you file that once you get the report back. So don't file it the day that you collected the sample. Wait till you get the results and attach it and file it. That's going to help with reimbursement. Reimbursement rates that we have been told of are between $40 and $140. So I don't know what amount that you guys need to attach, but $40 to $140 is kind of the range for insurance filing for cytology for dental. Now there is a second part of this, because when you send us a sample, we send that sample to the pathologist, and the pathologist bills the patient's medical insurance for the processing of that lab. Just like if you have blood drawn and they send it to a lab, you usually get an insurance bill or a notification from your medical insurance saying what the charges were for that lab. So what we need from you as the dental office is to get a copy of that medical insurance. Just a copy front and back, and include it in with this requisition form. Check the box that says medical insurance. And then when you send us the sample, we've got a copy and we just pass it on to the pathologist. Now, if the patient does not have medical insurance, they need to pay the lab portion, and that fee is $105. Or I'm sorry, it's $107. And so you would select the box that says patient, and you would include their credit card information on here so that they can be charged that $107 fee. So, for example, your patient doesn't have medical or dental. You're going to charge a fee for you to perform the procedure, and then there's going to be a fee for the lab to be processed. If you want to collect that whole amount up front, then you would collect, X the box that says clinician, and then you'll collect your portion plus the lab's portion, and then the lab's going to bill you for that $107 fee. Does that make sense?
We collect the fee portion and the lab portion?
If you want to do that option where it says clinician.
Oh, okay.
If they have dental and medical, then all you do is file their dental insurance yourself and wait till the report comes back and then file it. and then you're going to select you're going to X the box that says medical insurance, and you're going to put a copy of their card in there, and then that's it. So there's really no monies to be exchanged. We're just filing insurances in both directions. Now, all this is on our website, and when you get to the point where you need to do a cytology, if you have questions, just call us. We will help you through it because I know it's new, and you may have to call us a couple of times before you get the swing of it. But I would rather you call if you're not sure than wait till we get the lab, and then we're calling you saying, hey, this didn't happen, or we need this, and then the whole time it's holding up the patient getting their results. Okay? And then there is marketing opportunity. I'm sure DDP is kind of in charge of that, but if you have a website, update your website, advertise through social media. April's Oral Cancer Awareness Month, that's a good opportunity to do some sort of promotion, half-price screenings, or with every screening you give away a wristband, or maybe you have like a basket that everybody who accepts the screening goes into a drawing for this wine and cheese basket, or whatever. The list goes on and on as far as possibilities. You have in-office brochures. Sometimes at the front desk, when your patient checks in to see the hygienist and you greet them, you can hand them a brochure and tell them, we're really excited we have this new technology. Here's some information. The doctor or the hygienist will talk to you in a little bit more detail when you go back. So while they're sitting there waiting to be seen, they're kind of flipping through, reading the statistics, realizing that everybody's at risk for oral cancer. And so when they ask if it's okay if we do that additional test for $25, they have a little bit better idea. And also, the more they hear something, the more it sinks in. So you kind of talk to them about it, they read it, and then the hygienist talks to them about it, and you will hopefully have higher patient acceptance that way. Also, you want to put these posters around your office strategically because, again, it's just getting that kind of point of contact to let them know, it's not just about us trying to collect $25 and make money. It's about you go have a mammogram, you have a prostate test, we're doing oral ID exam, just like those other measures, so that we can hopefully catch things in early stages if there's something there to be caught.
Now, do you provide these marketing items, or we have to buy them?
They're for purchase. I'm not sure what the agreement is with DDP. I think you guys got so many brochures. Maybe you got posters, but that part I don't know, because with different group practices that we work with, some of them pay different amounts to be able to embody certain packages. And so I don't know what your guys' agreements are. But if you find that you don't have that stuff, you can either order on the website or you can call us. You may even have like a docket or something you have to go and order through. Do you guys have like a DDP order system?
Yes.
Yeah, and then it probably would be available through there.
Okay.
We do offer training for life, and so I recorded this training, so hopefully anybody that missed it, I can just email it over and they can watch it at their convenience. But we also do a course called Sex, Drugs, and Oral Cancer where you can get CE credit. This is something that if you're part of a study club or a dental group and you need a guest speaker, let us know. We may be able to come out and do that presentation for you. We also have a newsletter that we recommend you subscribe to. We always have promotions and contests. Any events that we're going to be at, we are advertising there. If you guys are going to sponsor an event, let us know and we'll advertise it for you on that newsletter. So it's just a good way to stay connected. Also, please go to Facebook and like us, because for every 500 likes we get, we donate a device to a nonprofit organization. We've given away 2. I haven't checked in a while, so I'm not sure how close we are to giving away 3. But the more likes we get, the faster we get to be able to give away another device to a needy community. The last little thing that I ask you is just keep us posted as you come across success stories. If you catch something in early stages or you get some good images of things that would be a good learning opportunity for other doctors, other clinicians, please keep us in mind and share that stuff if you think about it. We appreciate that. And that's it. You guys have completed the training, so I'm sorry for kind of taking over some extra time than what you had planned. Is there any other questions?